Welcome all to the SBA and EMQ Masterclass Session 2. All of you can hear me and see the slide. Am I
Yes,
audible
sir.
and clear? Yeah. So shall we start with the questions? Dr. Sinchana, you want to
Yeah.
go ahead?
Yes, sir.
Everyone should be active. Dr. Sansi, Dr. Tony, please participate actively. Okay. So I
Yes,
think,
sir.
yes. Dr. Sinchana first. Okay.
Yes, sir. A 28-year-old woman attends her booking appointment at 10 week of gestation. Her weight is 95 kg and height is 1.6 meter. Her calculated BMI is 37.1 kg per meter square. According to WHO classification, which BMI category does this patient fall into? A. Normal weight. B. Overweight. C. Obesity class 1. D. Obesity class 2. E. Obesity class 3. It's option D. Obesity class 2.
Yeah, very
More than
simple.
equal to 35.
Yeah, more than 40 is class 3. So remember,
Class.
below 40 is going to be this. But just take care of these borderline values, like 25, 35, 30, etc., etc., where these values are falling. Okay, so the class 2 is the correct answer. Next.
Which of the following best represents the approximate prevalence of obesity among pregnant women in UK antenatal population? Option A 10.5, B 15.7, C 21.3, D 33.8, E 47.3. It's option C 21.3%.
Yeah, this is a recall question. This has been asked in the past. Okay, so obesity affects approximately 21.3% of pregnant women in the UK in antenatal population, making it is a common risk factor in
Common risk factor.
obstetric care. Okay, so next question. Continue.
A pregnant woman with BMI of 42 kg per meter square, is seen at 32 weeks of gestation. Which of the following is most appropriate management regarding her anesthetic and pressure sore risk? A. Routine antenatal care without special anesthetic referral of or pressure sore assessment. B. Refer to an obstetric anesthetist for antenatal assessment and arrange a third trimester tissue viability test. C. Only arrange a pressure sore risk assessment in first trimester. D. Refer for anesthetic assessment only if she requests epidural analgesia in labor. E. Schedule pressure sore assessment for after delivery only. It is B. Refer her to obstetric anesthetic for an antenatal assessment and also arrange a third trimester tissue viability assessment.
Yes. Doctor, now you will understand that how clearly and minute reading is required for these particular guidelines. Okay.
Yes,
Suppose
sir.
if you have not read the guideline, if you look at these particular all options, you will really get confused which option to select. But what the RCOG is looking for, whether your advice is as per the guidelines or not.
Correct.
Okay. Okay, so the answer B is correct answer is B. Refer to an obstetric anesthetist for antenatal assessment and arrange a third trimester tissue viability assessment. So women with BMI more than 40 kg per meter square should have an antenatal referral to an obstetric anesthetist to assess potential difficulties with venous access and anesthesia and clear anesthetic plan documented. They should also have a tissue viability pressure source assessment in third trimester by a qualified professional using a validated scale. Next, wait, Dr. Tony, you want to go ahead with few questions? Anthony, Sansi, you want to go ahead with few questions?
Yes, sir.
Yeah, go
A
ahead.
32-year-old pregnant woman books for antenatal care at 10 weeks gestation. Her BMI is 36 kg per meter square, and this is her first pregnancy. She has no other medical problems or family history of preeclampsia. According to current guidelines, which of the following is the most appropriate management to reduce the risk of preeclampsia? No aspirin required due to lack of risk factors. Aspirin 75 milligram daily from 12 weeks until birth. Aspirin 150 milligram daily from 12 weeks until birth. Aspirin only if blood pressure rises in third trimester. Aspirin 300 milligram daily starting at 20 weeks. As B option, sir.
It is
Any
C.
other? Yeah,
C option.
Yeah,
it is 150 milligram.
150.
Now look
Right.
at this. Here, you please concentrate on BMI of 36 because the guidelines is
Mm-hmm.
30 words. Okay, if it would have been 32, then this will not be required.
Only one
Okay.
risk factor.
Only how many risk factor that you need to suppose. Apart from that also, if she would have been primary with twins with BMI 30, then she will require. Okay, because twins plus primary.
It's a risk
Okay.
factor. Minimum two risk
Ah,
factors.
you got it. Or if her age is more than 40, if they have given. So always two factors are required. Okay.
Yes, sir.
Aspirin 150 milligram 12 weeks. Okay, BMI more than 50. At least one other risk factor modifiable. First pregnancy, age, all these factors should be there. Okay. So next question.
A pregnant woman with a booking BMI of 38 kg per meter square is attending routine antenatal visits from 26 weeks of gestation. Which of the following is the most appropriate method to monitor fetal growth and presentation in this patient? Measures symphysis fundal height only at the booking visit, measures symphysis fundal height at each visit, and refer for serial ultrasounds due to BMI greater than 35. Use abdominal palpation alone to assess fetal presentation. Avoid ultrasound as SPH measurement is sufficient regardless of BMI. Refer for ultrasound only if SPH measurements are below the 10th centile. Sir, option B.
Yeah. Okay,
Option
major
B.
SFH at each visit and refer to ultrasound due to high BMI. Okay, so the option B. From 24-week gestation, SFH should be measured at every antenatal visit. However, in women with more than 35 kg per meter square, SFH may be inaccurate. So, referral for ultrasound assessment of fetal growth is recommended. Ultrasound should also be used to assess the fetal presentation if palpation is difficult. Okay, so this note carefully these particular sentences. Sansi, go ahead.
A 28-year-old multiparous woman with no pregnancy complications is planning her place of birth. She has a BMI of 32 kg per meter square but is otherwise low risk. Which of the following is the most appropriate advice regarding her birth setting? She should be advised to give birth only in consultant-led unit due to her BMI. She can be offered birth in a midwifery-led unit with clear referral pathways to CLU if needed. She should have an elective C-section because of maternal obesity. Birth in a consultant-led unit is mandatory regardless of risk status. She should plan a home birth due to low risk status. So option D.
Birth
Option
in a,
B.
yeah. See, here what we have seen that these patients, low risk patients or class 1 and class 2 can go ahead with a midwifery. If they
ML.
do not, because otherwise low risk they have mentioned. So she can be offered birth in a midwifery led unit with a clear referral
Clear
pathways to
reference.
CL if needed. Okay. And if
Yes.
it is a pediatric surgery, then definitely consultant unit. Okay?
CLE.
She can be offered birth in a midwifery-led unit with a clear referral pathways to CLE. Low-risk multiparous women, even if with class 1 or class 2 obesity, may be offered birth in a midwifery-led units, provided there are referral pathways to consultant-led units for any complications. Okay. Next,
Yes,
Sansi,
sir.
continue.
A pregnant woman with a BMI of 45 kg per meter square is admitted to labor ward in established labor according to best practice guidelines. What is the appropriate action regarding communication and documentation? The attending midwife should inform the on-duty anesthetist and document this in the notes. No special communication is needed unless complication develop. The anesthetist should be informed only if epidural analgesia is required. Communication should be made after delivery to plan postpartum care. Inform the anesthetist only if the woman has additional comorbidities. Sir, option A.
Correct.
Option
Okay.
A.
Yeah, the attending midwife should inform the on-duty anesthetist and document this in notes. Women with class 3 obesity admitted to labor require early communication with the on-duty anesthetist, and this should be documented by attending midwife for optimal care planning. Okay. Next, Dr. Sansi, continue.
During a C-section, the surgeon notes that the patient has subcutaneous fat layer thickness of 3 centimeter. What is the recommended surgical step to reduce the risk of wound infection and wound separation? Leave the subcutaneous fat layer unsutured to avoid tissue trauma. Suture the subcutaneous fat layer to reduce wound infection and suppression. Use only staples for skin closure without suturing fat. Apply a negative pressure dressing instead of suturing. Insert a subcutaneous drain instead of suturing the fat layer. Third option B or
Yeah,
E.
Option B.
yeah.
E is
We
B.
do
also.
get confused because our practice varies, no?
Yes,
Here in the examination, the guideline, we'll stick to the guidelines. Suture the subcutaneous fat layer to reduce the wound infection and separation. Okay. So correct
yes.
answer is B, suture the subcutaneous fat layer to reduce the wound infection and separation. In women with more than 2 centimeters subcutaneous fat, suturing the fat layer during the cesarean section reduces the risk of wound infection and wound separation. Next, continue, Dr. Sansi.
A woman has recently undergone bariatric surgery. When is it recommended that she waits before attempting to conceive to ensure optimal maternal and fetal outcomes? The option C, 12 to 18 months post surgery.
Correct, correct. So she has to wait for 12 to 18 months, that is 1 to 1.5 years. A waiting period of 12 to 18 months after bariatric surgery is recommended before conception to allow weight stabilization and identification and treatment of nutritional deficiencies. Okay, so that is what is the reason for which she has to wait. Dr. Sinchana, anyone else wants to
Yes, sir.
continue? Anyone else is there to continue, or if no one is interested, Dr. Sinchana, continue. Go ahead.
Yes, sir. A pregnant woman with history of bariatric surgery presents for antenatal care. What is the most appropriate model of care? A. Routine midwifery led antenatal care. B. Consultant led antenatal care with nutritional surveillance. C. Community based antenatal care without specialist involvement. D. No additional care required beyond standard pregnancy protocol. E. Antenatal care led solely by a dietitian. It is B. Consultant led antenatal care with nutritional surveillance.
Correct, correct. So it's very straightforward. Consultant-led care with nutritional surveillance. Pregnancies following bariatric surgery are high risk, requiring consultant-led antenatal care and close nutritional monitoring. Now EMQs. Dr. Sinchana, continue. So these are the options. I will show you the
Yes, sir.
questions. Then you look at the options. You need not read, but loudly all options. Look at the options. We can use the timer also, because 2 minutes we can allot for the reading, as well as you need to read the questions loudly, but options you need not read. Okay, just
Okay, sir.
read them.
A 32-year-old woman, G2PO, presents to emergency department with history of lower abdominal pain for past 24 hours. The pain is sharp, consistent, worsens with movement. She is 6 weeks pregnant, confirmed by UPT, and her last menstrual period was 8 weeks ago. She has history of one previous ectopic pregnancy diagnosed at 8 weeks, underwent salpingectomy on left side. Vitals are 110 by 70 BP, pulse 92, temperature 37.2 degrees Celsius. RR 16 breaths per minute, saturation 98%. On examination, the abdomen is tender on the left lower quadrant, and pelvic exam showed cervical motion tenderness. A transvaginal ultrasound revealed a right-sided ectopic pregnancy with no evidence of live intrauterine pregnancy. What is the most appropriate surgical management for this patient? Their
Options.
option. It is a laparoscopic right salpingostomy.
So option
H.
H. Correct, correct. Okay. This is the laparoscopic right salpingostomy. See, actually, you look at this and you, okay, salpingotomy is required. Okay, okay, just mark this. No, no. You look at carefully. Then sometimes this right, left, you don't look, because one of the option is just laparoscopic salpingotomy. Okay, laparoscopic, then you may think of that. But the left side, she is already undergone salpingectomy. So you need to go ahead with the conservative laparoscopic route is better. You have to note the side on which you are going to operate. So the best option is going to be the laparoscopic right salpingotomy. You got it? So that is
Yes.
why EMQs are little difficult. You feel that that option is correct, but whether that is best or not, that we do not. Okay. And reading the here you have to read very fast in the exam. Just look at the sign vitals. Okay, vitals are stable. Okay, this is the point which they want to communicate. So no need of reading in the final each and every point. You have to save the seconds and second. Yes, go ahead with the next question, doctor.
A 34-year-old woman, G1P0, presents with dull lower abdominal pain that has been persistent for last 48 hours. She is 7 weeks pregnant. History of 2 previous abdominal surgeries due to appendicitis and pelvic inflammatory disease. She has been trying to conceive for 3 years with no success. Her BMI is 31. She is nulliparous. Her vitals is BP 115 by 70, pulse 95, temperature 37, RR 16 per minute, saturation 98% in room air. On examination, the abdomen is tender with rebound tenderness in lower abdomen. Pelvic exam shows cervical motion tenderness. Transvaginal ultrasound shows ectopic pregnancy in the left fallopian tube, and a contralateral tube appears normal. What is the most appropriate surgical management for this patient? So it will be laparoscopic
Mhm.
left salpingectomy.
Left salpingectomy
Salpingectomy.
because contralateral tube is healthy, is
Healthy.
it? What
Yes,
about
sir.
she is trying to conceive for 3 years? What about there are previous abdominal surgeries
Okay.
due to appendicitis? There is a PID. What do you feel? Are there any subfertility factors associated
There
in
are
this
some
patient?
fertility, so left salpingotomy,
So do you
laparoscopy.
feel that if she undergoes salpingectomy because of this, what is going to happen with the subsequent pregnancy outcome? We have discussed all rates and everything. It might not be in your mind immediately, but you have to read the whole scenario, whether the what the guidelines is: patients with subfertility factors, patients without subfertility factors. So here your answer, these are the points. Okay.
Yes, sir.
And this is ultrasonographic finding. Okay, it is not a laparoscopic finding also. Got it?
Oh, good. Yes, sir.
So the option will be laparoscopic left salpingotomy.
Salpingotomy.
Okay. Now the next question is about information about salpingotomy and follow-up care. Okay. What is going to be the continue, Dr. Sinchana? This is the question option I will show you.
Yes, sir. A 29-year-old woman, G2P1, presents with lower abdominal pain. She is 6 weeks pregnant with confirmed ectopic pregnancy in right fallopian tube. She has history of 1 previous ectopic pregnancy and previous PID. After discussing treatment options, she and her obstetrician decide on salpingotomy to preserve her fertility. The procedure is successfully completed. What important information should be provided to this patient after undergoing salpingotomy for a ectopic pregnancy? Sir, it's option C, where a follow-up serum beta HCG level is essential to monitor for persistent trophoblast tissue.
Correct. So the option C, follow-up serum beta ICG levels are essential to monitor for persistent trophoblastic tissue. Okay. What is the persistent trophoblast rate following salpingostomy? How many percentage patients are likely to have after salpingotomy and after salpingectomy?
Salpingectomy is less than 1%.
Yes, and
Salpingotomy, 40, 1/3.
no, it is 7%.
Okay,
Okay,
yes, sir.
and the value which is given is somewhere around I think 6 to 13 or 5 to 13, or that I said the average comes to
Average is
7.
7. Yes, sir.
You got it? You remember those? So
Yes, yes, sir.
if you just remember, listen to all lectures carefully, no, even the numericals will not be a problem. Okay. So
Yes,
next
sir.
question, continue. This is question is based on the so you have to read the stem. Okay. Remember here in SBA, what the this particular question is related to, this particular stem is going to be very important. So read this stem and start reading the question. Okay.
Yes, based on the clinical scenario, which of the following management options is most appropriate for this patient's ectopic pregnancy? A 28-year-old woman, G1 P0, presents to emergency department with vaginal bleeding and a positive UPT test. She is clinically stable with no abdominal pain. The vital signs are normal: BP 110/70, pulse 78, temperature 36.8, saturation 98%. On TVS, a tubal ectopic pregnancy is identified with no fetal heartbeat and measures 30 nm. Her serum beta HCG level is 950 units per liter. She has no significant past medical or obstetric history, no risk factors for ectopic pregnancy such as PID or previous ectopic pregnancy. After discussing the options with patient, you're considering the most appropriate management plan.
So look at the
Yes.
important values and then
Um, Option A, expected management.
why you say the expectant management.
So because her the two ectopic pregnancy has no heart cardiac activity, also measures less than 35 mm, and her beta HCG level is less than 1000, and she is clinically stable with no pain
Correct.
abdomen.
Correct. Okay, the answer is expectant management. Okay. I think this is the last question. Go ahead with this.
A 26-year-old woman, G2 P0, presents to emergency department with vaginal bleeding and positive UPT. She is clinically stable, pain-free, no abdominal pain. The vitals are normal. BP 115/75, pulse 80, temperature 36.7, saturation 98% in room air. On TVS, a tubal ectopic pregnancy is identified, measuring 30 mm with no cardiac activity. Her beta serum is 850 units per liter. She has no history of pelvic inflammatory disease, no previous ectopic pregnancy, no abdominal surgery. She is offered choice between expected management and medical management. She decides to proceed with expected management after a thorough discussion about the benefits, risk, and follow-up requirements. Given that this patient is eligible for expected management, what is the correct follow-up protocol for monitoring her progress?
So what they are asking is the correct follow.
So it is check beta HCG levels on day 2, 4, and 7. If it decreases by, it is option A. If it decreases
Option.
by more than equal to 15%, then we have to continue monitoring weekly until the HCG level is less than 20 units per liter. If no
Correct.
drop, rise, or plateau, reassess
Correct.
and seek
Correct.
senior review.
So now you understood how confusion can happen with various options. Okay. So if you
Yes, sir.
know the protocol very clearly, then only you will select the right options. At least I have given 5, but in the exam there might be 12 or 15 options also. Okay.
Yes, sir.
So this is the check serum beta HCG on day 2, day 4, day 7, and the value should decrease by more than 15%. I think there is one more question. Go ahead with this question.
A 30-year-old woman, G3P2, presents to emergency department with history of abdominal pain and vaginal bleeding. She is diagnosed with tubal ectopic pregnancy after positive UPT. On TVS, a tubal ectopic pregnancy measuring 40 mm is identified and fetal heartbeat is detected. Her beta HCG level is 1500. The pregnancy has history of one previous ectopic pregnancy and PID. After discussing treatment option, patient decides to proceed with medical management using methotrexate after being fully informed about the risk and benefits. Given that this patient has been prescribed methotrexate for the management of her ectopic pregnancy, what is the correct follow-up protocol for monitoring her progress? It is option B. We have to check her beta HCG on day 4 and 7. And if it decreases by more than equal to 15%, we can continue weekly until HCG is negative. or if it
Correct.
rises, plateaus, or reassess, we should
Correct.
consider surgical management
So
or
what
additional
happens?
treatment.
Yeah, with this stem only, they will give 5%, 10%, 15%. So they will make 3 stems of this. They will make day 2, day 4, day 7, same stems of with 5%, 10%. Okay, something like this. Okay, day 2, day 4, day 4, and they will create 12 or 15 options. So do not get confused. Stick to the protocol. Okay, so correct option
Yep.
is B. So you have to do it on day 4 and day 7. Okay, so that finishes today's SBA masterclass, EMQ masterclass also. Thank you all. Thank you for attending the
Thank you, sir.
session.